So Lindsay and I were talking about this before. Like CPR uh, is much more comprehensive and much more applicable. I think not that FTM and MSK were easy, but it was kind of like a prequel to like actually learning about practicing medicine. Like CPR, like cardio felt like we were actually getting into like, the day to day, because regardless if you're in surgery or internal medicine or family medicine, uh, the heart is such an important aspect of what you're going to do. So this seems it seems like it was kind of like the real introduction into actual medicine. So with that being said, we're getting away from the memorization and the a lot of the buzzwords, and it's more of a conceptual aspect. You really need to be able to close your eyes and like wrap your head around what's going on, because the questions they ask. Um, Let me just type scrubs. DES is the scrubs room. So yeah, you're going to see some buzzwords, but a lot of the questions you're really going to have to close your eyes and say, look, if the preload changes here and the afterload, and you really need to wrap your head around what's going on in the heart. So we're gonna teach you kind of like we tried to learn it, and it's going to be very much like to conceptualize, to actually understand what's going on. So with that being said, let's get started. Scrubs DES, you could find the review slides there. Lindsay's review slides are on Dogmom DES if you want to annotate them. I put a bunch of stuff and additional resources on the drive that includes a bunch of questions you can use, practice questions, old IEA questions, which I found helpful. Okay, so the way I think of the cardiovascular system is actually two separate systems, okay? You have the left heart and you have the right heart. And the reason I do that is because if it was a simple pipe system, it'd be easy to understand. We put pressure on one side, it goes straight back to the other side. And the rudimentary aspect of cardio is that, but it's not like that at all, actually, because once you get to the capillaries, from the arterial side, you're dissipating the pressure. And the venous side, the blood doesn't go straight back to the heart. It pools in the venous side. There's like literally pools of blood. And as you need blood to go back to the heart, the venous constriction, or the veins constrict to allow blood to go back to the heart. So the way I like to understand it is that you have a left heart side and a right heart side, and they're two completely different systems. And what you'll see is that when you start looking at the equations are going to be, you're going to use like mean arterial pressure, and you're going to be thinking about the left heart side. And then you're going to see equations that involve central venous pressure. And on that, you're going to be worried about the venous side. So I like to keep them completely separate. So go into that with that knowledge, and I think it'll help out a lot. Secondly, there's a delicate balance with the heart too. Okay, so you might say, well, I want a really strong heart. I want my heart to be as strong as possible. But a strong heart means the muscles are gonna hypertrophy, right? They're gonna get bigger. And if the muscle's too big in the heart, then the chamber gets small. So there's a delicate balance. You're gonna see both ends of it, a weak heart and a strong heart. You kind of want to be in the middle, okay? All right, so just a couple of things if you remember from undergrad, when you learned in what was it? I don't remember, but like pumps in a series, right? And right, so this is how it's basically going to be, right? You have arteries that are going to go to arterioles to capillaries, and it's going to be a series. But you also have situations where you're going to have the vessels in a parallel arrangement. And this is going to be a little more complicated because say you just eaten a big meal, you're going to have vasodilation to your gut, whereas some areas, particularly the limbs, are going to be vasoconstricted. So this makes it a little more complicated when you think about the blood flow, because it's in constant variability to where the blood's going to be actually diverted to. I put stars on this slide. You're going to get to these equations later, but the sooner you learn them, the better. These are going to be three of the major equations that that you're going to want to remember. All right, so quickly, let's do some histology stuff. This is just to get us warmed up. Let me get Socrative loaded up. All right, you should be able to see the question. We'll go quickly through these histology questions, but I just wanted to add them in there because when you get to these problems that involve the cardiac physiology that get really complicated, a lot of these histology questions are going to be the easy ones, the gimme questions. So you're going to want to make sure you get all these right. Looks like y'all are doing good with this. Yeah, very good. Okay, so yeah, so obviously tunica intima, the atheromas, the fibrofatty plaques, you're going to get atherosclerosis. Very good. And we'll go quickly through this. See, when you have high fat diets, a lot of cholesterol over time, you build up these plaques. The point is that they build up in the tunica intima, which is the layer closest to the lumen, right? And then through this histopathogenesis, a lot of times you get injury. And we know when we get injury and we involve macrophages and stuff, you can develop scar tissue. So over time, the vessels don't have the same compliance. And by compliance, I mean elasticity, or how compliant they are to the incoming blood, right? So how much they allow the blood to come in. But when I think of compliance, I think of elasticity, right? So as these vessels get scar tissue and they get sclerotic, they're not going to be as compliant. They're going to be stiff. All right, try this one. Physics, that's what I was thinking of. You remember the pipes in a series or pipes in a parallel pipes? It's physics.
Yeah.
Yeah, like the 1/r and physics, gross. All right. All right, so yeah, let's look at this quickly, right? So we're looking at, you could tell that this is skeletal muscle. You could see the nuclei is pushed to the edge of the cell. So by definition, if you look at these, the only definition that works is that if you have tight junctions, you're going to have a continuous basal lamina. You can compare that to fenestrated vessels that have holes in it, but they don't have a continuous basal lamina. And that allows nutrients or blood or whatnot to pass through it. So yeah, you want to look at this continuous capillary. You can see here there are no little holes in there of fenestration. Cool, try this one. I think one of the really important things about the histology with the vessels is understanding where there are differences. So like when you have like the aorta, for example, versus the muscular artery versus arterioles, what are the differences in the layers, between the layers? Which ones have an adventitia, which ones have a thick tunica media or an elastic tunica media. So appreciate the differences you'll see there. Okay, here. Does somebody want to walk me through this? Yeah, so A is the tunica media. What's this little arrow right here?
Well, tunica intima.
It is, right? And then B would be?
Adventitia.
Yeah, exactly, right? So one of the interesting things about the aorta, if you see here, is this thick tunica media has elastic fibers. And what that does is when the blood comes into the aorta, it has this recoil effect. So it'll actually kind of go around the incoming blood and continue to push it down. So you get unidirectional blood flow. So it has this recoil effect. And that's because of this thick tunica media, these layers. All right, let's try this one. All right, cool. So yeah, y'all are getting this. Myocardium, right? So we say here that it is in the wall of the heart, and you can see here that thick layer is the myocardium. The endocardium here, you're gonna have is gonna line the chambers, and then the epicardium will be on the outside. If you compare this H&E stain to the previous one of skeletal muscle, you can appreciate that the cardiac muscle, though it's striated, you can differentiate it from skeletal muscle because cardiac muscle has this branching pattern. You can see it here. Sometimes it's multinucleated, but the thing that stands out to me is kind of these branches you see here. So make sure you take note of that.
I have a
All
quick
right.
question, sorry.
Yeah, sure.
You can refer to the layers of the heart as tunica, intima, media, and adventitia, but you can't refer to the layers of vessels as endocardium, myocardium, right? Because if you look at the slides behind it, it says like, oh, endocardium is tunica, intima, myocardium, media.
Yeah, you can do that, but typically it's considered endocardium, myocardium, and epicardium. Like I think if they put it on the test, they would put that, and they would leave the intima to the vessels.
Yeah, the cardium just refers to the heart, so essentially they're renaming it. So think of like in MSK when you had an artery that goes to the body, when it changes position in the body, they're just going to change the name of the artery.
Okay, so basically for vessels is tunica and for the heart is the myo, right?
Yeah, exactly. Yeah. All right, let's see. Cool, right, so y'all get this. What you're looking at here is atherosclerosis. So, I mean, obviously this is a problem, right? I mean, the blood flow here is less than 50% of the actual vessel. So if you have part of this plaque break off, you can get a stroke, you can get a myocardial infarction. A lot of problems go into this. So this is why you try to keep your patients on the low-fat diet and low cholesterol diet. Cool. Again, this is the histopathogenesis slide. You just don't want to negate the fact that the scar tissue formation is going to cause a problem down the line. All right, so let's look at this. This is the mediastinum stuff. So we'll slow down a little bit for these questions. Histos you kind of identify the picture, but I want y'all to read these carefully. All right, so this is a good example of a question where you're taking a clinical aspect and you're bringing in the anatomy component to it. And one of the cool things about medicine and being a doctor is like if you're at home, if the patient's at home and he's looking up on Google hoarseness, you might not come across that. It's probably it could be a problem with your heart, right? So this is a great example of a question they could ask where a patient comes in with hoarseness. It's like, well, it can actually involve the heart, right? So the key thing here is that it says, oh, look, a growth next to the aortic arch. So if you hear hoarseness and you see there's maybe a problem with the aortic arch, you need to remember that the left recurrent laryngeal nerve kind of loops around there, right? It does loop around there. So it's a branch off the vagus. So on the left side, it's going to loop around the aortic arch. And so if you get compression of the left recurrent laryngeal nerve, you can get hoarseness. So a great example of a symptom that you can get that doesn't seem to involve the heart, but it actually does. Keep in mind that the right recurrent laryngeal nerve actually goes around the right subclavian artery. Not as important clinically, but you just want to make note of that. We're going to get into the embryology of this later on, but just a good example of a question that involves kind of a systemic approach to medicine. All right, try this one. All right, so it looks like we're between phrenic and vagus, which, so let's try to differentiate the two. This is another example. Patient comes in with dyspnea, difficulty breathing, right? So what is this? What is this? This association with pain over the left shoulder. What is this?
Referred pain.
It is, right? From where?
Diaphragm.
Exactly. So you're thinking, interesting scenario. We got difficulty breathing, referred pain from the diaphragm. If we remember, C3, 4, and 5 keep the diaphragm alive. So C3, 4, and 5 make up the phrenic nerve. So again, we're talking about breathing problems. You got some sort of musculoskeletal problem. Actually, it could be a problem with the heart. So again, we're talking about this aortic arch, right? So if you look here, this kind of greenish yellow, that's the phrenic nerve. Vagus was a good guess, but we need to go a little bit further to differentiate if it's phrenic versus vagus. So you can see the left phrenic runs next to the aortic knob right here. And if it goes down, if you have some sort of compression here around the aorta, it can affect the diaphragm down here, and then you can get difficulty breathing. Good. All right, let's try this one.
I just have a quick question. I thought vagus
Yeah.
nerves has sensory innervations as well.
It will do sensory innervation primarily in the larynx and stuff. But when we talk about the diaphragm specifically, we're talking about the phrenic nerve.
Thank you.
Yep.
Especially with that referred pain to the shoulder, that's very characteristic.
Yeah.
Pleural related shoulder pain.
Right, exactly. Lindsay's right. You don't want to look over that because it's kind of one of those outliers in the question that they want to throw in there to make you specifically think of the diaphragm.
What would have made that question, like what would have been a buzzword for me to choose vagus nerve then?
So go ahead, Lindsay.
For the referred pain, it wouldn't be vagus though.
Yeah, you would
It would have been a
eliminate
completely different scenario.
Okay, thank you.
Yeah.
Vagus nerve could controls parasympathetics to the heart, so they could go there. They could talk about, I mean, yeah, they were, yeah, because usually, I mean, when you think of the vagus, you're thinking, you know, it kind of goes to it carries parasympathetics to the heart, so they definitely wouldn't use the diaphragm analogy. Okay, let's see. Okay, so if we look at the answers here, first we need to use the test to your advantage. So we want to choose first, are we going to think about esophagus or aorta here, right? And if I see a gas-filled structure, it's probably not the aorta. I would say esophagus just because if it's gas-filled, maybe the patient must have swallowed some air, right? So we do have, so then we have to know at what level, right? Does anybody know the mnemonic to remember what levels everything pierces the diaphragm?
I ate 10 eggs at 12.
Yeah, right, exactly. So we can find esophagus is at level 10. If you don't know it, it's I, 8, so inferior vena cava at 8, 10 eggs, esophagus at level 10 at 12, right? So if you look here, inferior vena cava, esophagus, and aorta, 8, 10, 12. Easy way to remember it. Cool, so let's go over some of the anatomy of the heart. All right, so let's look at this. So we're going to do a pericardiocentesis, right? So we're going to try to get fluid. We're going to aspirate fluid from the pericardium, the infrasternal area angle, right? So if on me you see the heart's kind of lay like this, right? So the left ventricle is going to be towards the apex midclavicular. So if we go infrasternal, we're kind of going in this area here, right? Right around the sternum. So if you do that and you're coming from anterior towards the heart, you're going to probably pierce the most anterior aspect of the heart if you go too far. So that would be the right ventricle. You can see here, when you get pericardial fluid or pericardial effusion, you can see this darker brown area here. That's where it's going to collect. It's important to know there's a fibrous pericardium and a serous pericardium. The serous pericardium is made up of a parietal layer and a visceral layer. Obviously, the visceral layer is going to be the closest to the organ or the heart, right? And you can see here, if you see this, you see that how it's fuzzy around the heart, that's going to indicate there's fluid. And if you see here, this is a T2 weighted MRI. So that means the fluid lights up and you could see this fluid here. So if you do a pericardiocentesis, you're going to want to come in and aspirate this bright area, this fluid. All right. Let's see, this is kind of talking about some similar scenario, but this is very high yield.
Ice pick.
You need an ice pick question for sure. So this is those questions that one of those ones that aggravates me where you read it and like you get to the second line and you're like, this lady probably has cardiac tamponade, and then you read here that it tells you that they do, and you're like, oh, I just diagnosed it, and then they're going to tell me the actual what it is. That gets aggravating. But anyway, they don't even have to tell you that it's cardiac tamponade. But since they did, we know that one of the components of cardiac tamponade is diminished heart sound. So we'll go through this quickly. So there's a traumatic accident here, right? So there's a blood-filled cavity around the heart, fluid-filled. In this case, it's blood. So if you could imagine this blood around the heart, we're going to get symptoms associated with it. So why would you get hypertension? Well, think about it. If you have blood surrounding the heart can't fully expand because of that fluid around it. And since the heart can't expand, you can't get blood into the heart. So if you can't get enough blood into the heart, the blood coming out of the heart is going to be decreased. That would give you hypertension. Distant heart sounds, if you can imagine trying to listen to a heart through fluid, it's going to be muffled or it's going to sound like they're distant. The reason you get distended neck veins is because, again, if the heart can't expand properly, then you're going to get a backflow of venous blood. And when you get a backflow of venous blood, it's going to collect in the venous system. This is called jugular venous distension. So if you see this triad, Beck's triad, immediately you want to think about cardiac tamponade. Treatment, again, is a pericardiocentesis. You got to get the blood out so the heart can properly expand. All right, a couple more anatomy questions. Oop. All right, and y'all got this one good. So Right, so we're talking about a trauma, a blunt force trauma to the sternum. The most anterior aspect of the heart is the right ventricle. We'll look at a picture in a second. I want you to answer this question first. This is super high yield. Towards the end, I'll show y'all some images. I know sometimes these images get daunting, but you just kind of have to sit down with it and just like give it some love and just like try to try to imagine what's going on, because the sooner you orient yourself to these pictures, these questions get easy when you're able to figure out what's going on. So those I think it was a DLA they gave y'all that has the images. Just kind of sit there with it, orient yourself. So if we look here, obviously this is the vertebral body. So the patient's laying on their back. Remember, when you look at these scans, the patient's feet are coming towards you, okay, out of the screen. So their head is into the screen. So you want to orient yourself that way, making this side the left side, this side the right side. Since the bones are lit up white, this is a CT scan. So we're talking about here that there is a carcinoma in the esophagus, right? So you can see this darkened area here, that's the esophagus. So we're asking if the carcinoma increases in size, what's the first part of the atrium of the heart to be affected? And that's going to be the most posterior aspect of the heart, which is the left atrium. The better question they could ask is, a patient comes in with dysphagia, difficulty swallowing, and you're thinking, or the patient's thinking, I don't know, something wrong with my esophagus or my, something like that. But you need to immediately think, possibly the left atrium is enlarged. Okay, so even though it's a problem swallowing maybe his esophagus, you need to remember that a left atrial enlargement, some sort of pathology causing the left atrium to be enlarged, can compress the esophagus because it's the most posterior part. That's the question they'll probably ask. Okay, so if a patient presents with dysphagia, you can think left atrial enlargement, because that's the most posterior aspect. You can see here, since this is the left side, this large vessel here is the descending aorta going down, right? Again, the patient's feet are coming out towards you. If we look at the sternum here, remember that traumatic injury to the sternum, this is going to be the right ventricle right here. And you can see the septum is right here. Actually, it's kind of, yeah, it'd be like right in this area. This larger area is going to be the left atrium, but it's just the cut that they used right here. Right, so if we look here, this is the better cut. You can see the left atrium back here next to the esophagus. The right ventricle here is next to the sternum. And you could see on this cut specifically, if you had an injury to the sternum here, it would affect the right ventricle, the most anterior component. Over here is the apex toward the left side of the heart. And again, you could see the descending aorta coming down here. All right, let's look at the chambers. All right, looks like y'all get this. If just by knowing we're thinking about the left ventricle, right? So the left ventricle, the valves between the AV valve, which is the mitral valve, which is between the left atrium and left ventricle, you don't want those valves to pop back into the left ventricle, because then blood's going to go backwards. So what prevents this is the chordae tendineae, and I'll explain it with a picture in a second. So one of the anatomy things you need to remember is kind of where some of these structures are in the hearts. So you're going to have like this pectinate muscle in the right atrium. You can see here the fossa ovalis. That was the remnant of the foramen ovale that embryologically is between the atrium, the atria, and let's see, left atrium here. Again, you can see the fossa ovalis there. Here's what I want to show you. So the left ventricle, you see these, this is the chordae tendineae, which literally means tendinous cords. So the idea is that when blood goes from the left atrium to the left ventricle, the mitral valve closes or opens like this, right? Allows blood in. And then once it's full, the mitral valve and tricuspid valve, it pops back, right? And then these cords hang from the bottom that hold it like right middle like this, in the middle, so that the cords that are below it can prevent it from popping back up. Because if they pop back up, you can get mitral valve prolapse, right? But if that's the case, then you can get mitral regurgitation. So it's kind of cool that there's these cords right here that kind of keep the valve from going up. It's necessary. Now the semilunar valves aren't going to require that because it's a low pressure system when it's empty when the heart. I'm sorry, they're closed when the heart's filling. So it's not such a severe pressure as with ventricular contraction. Right, again, so tricuspid, 3 cusps. There's the chordae tendineae. Bicuspid is mitral, so you have 2. You can see that here. And then, like I said, the semilunar valves, they aren't undergoing as much pressure when they're supposed to be closed. So they have semi-lune or half moon or partial moon valves here. And those are going to be the aortic and pulmonic valves. We'll get into the murmurs a little later, which are super important, but you have to understand normal before you can understand abnormal. So if you auscultate, this is really important because when we talk about the murmurs, they'll tell you you're listening and the murmur is loudest in the second intercostal space, or the apex of the heart. So you want to remember aortic, pulmonic, tricuspid, mitral. All physicians take money. That's the mnemonic they use. So aortic is going to be second intercostal on the right side, and then you're going to move to the left side, pulmonic, second intercostal on the left. Tricuspid is around 5th peristernal on the left, and then 5th or 6th, they say 5th here. The apex is midclavicular, is the mitral. Okay, so you want to keep that in mind. That it's more important to know where to auscultate because that's not actually where the valve is. That's where the sound from the valve is heard the loudest. Okay, so if you remember that, then keep in mind that the valves are more medially located. So whereas second intercostal space is where you listen to it, those valves are around third intercostal space, and here the fourth or the 5th intercostal space where you listen, the valves are a little bit more centralized, okay, to where around the 4th. All right, try this question.
I'm sorry, can you say the mnemonic again?
Yeah, so it's, so starting with aortic on the right, it's all physicians take money. So aortic, pulmonic, tricuspid, mitral. There's probably more politically correct mnemonic to use, but that's the one I know.
None of our mnemonics are nice and pretty and appropriate.
But you will remember them. Yeah, so it's all physicians take money. Aortic, pulmonic, tricuspid, mitral. If you keep that in mind, that's just, even when you're doing your OSCE or whatever, or OSPE, whenever you see a patient, just listen to them in that order. All physicians take money. Just kind of go from right top to left side.
Oh, geez.
Is the chat blowing up? I can't even see it.
No, people are just putting in different mnemonics.
A priest touched me. That's a great one. That's funny. Okay, let's take a look at this. Right, so this is a good example. We got a murmur, a systolic murmur at that, and we're saying the second intercostal space on the right. So that's the first spot, right? Aortic on the right, the only one that's on the right, and that's where you start. So we know it's the aortic valve. All right, what are they asking? What chamber or vessel receives blood? So the aortic valve means you're going from the left ventricle to the aorta. So the answer should be aorta, right? And then what kind of murmur are we talking about here? Does anybody know? Tells us it's a
Aortic
stenosis.
stenosis.
Exactly, right. And we'll get into these later because it's super important. Maybe the most important thing we're going to do today, but it's besides the PV loops. But yeah, so you're right, a systolic murmur. So we're going to, in the aortic region, so it's aortic stenosis. Very good.
Can you please explain
here-
what you said about where the blood is coming and going to?
Sure, yeah, okay.
you.
So we're talking, okay, so first let's identify the valve. It's a systolic murmur, which is loud, which is heard loudest in the second intercostal space on the right. Let me go to the next slide real quick, and then I'll show you. Second intercostal space on the right, that's the aortic valve, okay? So remember, all physicians take money. So we're the second intercostal space on the right. So if that's the aortic valve, we know that that valve is between the left ventricle and the aorta. So the question asks us, where's the blood going after it passes that valve? So it's going from the left ventricle past the aortic valve into the aorta. So that's what they're asking. Right, so if they asked you, you heard a murmur, parasternal on the left, fifth intercostal space, immediately you know it's tricuspid. If you heard a murmur, fifth intercostal space, midclavicular on the left, you're thinking mitral, right? Or if they say the apex, you heard a murmur best at the apex, that's the mitral. This little region here is the apex of the heart. So that'll identify the location. And then from there, you need to determine, is it a stenosis or is it regurgitation? Once you identify the valve, but we'll get into that in a little bit. Blood supply, I know this always bothers people, but for the heart, it's pretty straightforward. So off the right coronary, in most people, the posterior interventricular artery comes off. It's also called the PDA, posterior descending artery. I like that to say it like that because it's quicker. You could just say PDA, but I'll try to say them both just to not confuse anyone. So typically, the right coronary is going to give rise to the posterior interventricular or the PDA. Also, some of these smaller ones, the sinoatrial nodal artery is going to come off because that's where the SA node is. You're also going to get these right marginal arteries that come off too. We'll talk about the veins in a second, which are important. Off the left coronary artery, you're going to get the left interventricular. I'm sorry, the anterior interventricular artery, which is also known as the LAD, left anterior descending artery. So what's important about this LAD, which comes off the left, right? The LAD is also called the widowmaker. And that's because if you get a heart attack or a MI, a myocardial infarction in the LAD or the anterior interventricular artery, it's really bad, okay? So the problem is if it gives blood to the left and the right ventricle in the anterior side. So if you get some sort of blood clot there or have an MI, you're gonna get decreased blood flow. You can get ischemia to the muscles of the heart, and that's a really bad place to get it. So if they talk about that, that's really the worst place you can get it. All right, this is from first aid. It's kind of color coded. Just remember, typically off the right coronary artery, you're going to get the PDA, and off the left coronary, you're going to get the LAD, right? And also this left circumflex artery that kind of loops around. All right. Let's try this one. All right, a few more seconds. Okay, so I don't want you to get confused with this dominant, this aspect of dominance. All that means, all we're asking is where the posterior interventricular artery comes from, or the PDA. If it comes from the right, you have a right dominant heart. If it comes from the left, you have a left dominant heart. So all they're asking here is if you have a left dominant heart, what artery is going to come off of? So for left dominant heart, it actually goes from the left coronary to the circumflex to the posterior interventricular. But the point of dominance, as you can see here, 60% of people are right dominant, which means the posterior interventricular, or PDA, comes from the right side. 23% are left dominant, which means the posterior interventricular, or PDA, comes from the left side. Don't really concern yourself with codominance. Just know that if they're talking about dominance, all they're asking you is about the posterior interventricular, or PDA. All right, here's the veins. This is high yield as well.
Brady, are your answer choices on Socrative different than on the slides?
No, they should be the same.
Just the order.
The order is different.
The order of the question?
No,
Yeah.
no, the order of the answer.
Oh, sorry about that. I don't know what happened. Were they still correct though?
Yeah.
Okay, cool. As long as they're right. Yeah. You have to manually copy and paste everything to Socrative. So sometimes late at night, my brain gets confused.
Thank you so much for putting in the work. Appreciate it.
Oh, no worries. No, it's all good. All right, we'll wait a little bit longer. All right, so we're between two, which is what can be expected, just because these are the two you really need to know. So for this one, we're asking which vein runs with the anterior interventricular, or LAD. That one's the great cardiac. The middle cardiac is going to run with the posterior interventricular, or in the back. So if we look here, this is the apex of the heart. This is the left coronary. This is the left anterior descending, or the left interventricular. So the great cardiac is going to run with it. Great in the front, middle in the back. Just remember that. Great in the front, middle in the back. So the middle is going to run with the PDA, or posterior interventricular. I think that'll probably be as far as they go. I mean, you can learn these marginals and stuff. And obviously the coronary sinus is kind of that confluence where everything comes together and drains back into the right atrium. But just remember for right now, great cardiac in the front, middle cardiac in the back. Put this in here. This is kind of just breaking it down for you. Right, so right coronary artery, typically PDA, or posterior interventricular, is going to come from the right side. That would be a right dominant heart. All right, quickly, we'll talk about the nerves. Sympathetic innervation, remember the sympathetics are thoracolumbar, okay? So any sort of innervation from the heart would be from the T1 to T4 from that sympathetic chain. For the parasympathetics, as we kind of touched on earlier, it's going to get innervation from the vagus nerve, which is coming from the cranial region. All right, try this one. All right, so this is classic, right? Patient comes into the ER, feels like an elephant sitting on his chest, then he gets pain down his left arm. What is this pain called that he's feeling down his left arm? We touched on it earlier.
Referred pain.
Referred pain?
It is. Yeah, exactly, right? So the visceral pain from the heart is because they cross, they come close to the somatic or somatic afferents, afferents meaning sensory. They come close, you're going to get this pain sensation in the visceral, or excuse me, in the somatic area or your musculoskeletal area. So this specifically is the intercostal brachial. Again, we said visceral afferents are going to carry those pain fibers from the visceral, meaning the organs, right? And it's going to kind of attach itself or kind of run close to the somatic fibers. So if you see this blue here, that's the intercostal brachial. So that's where the patient's going to feel this pain. You can see red here, right? So that would be indicative of an MI or a heart attack. All right, now
What's the difference
the
between
fun stuff.
the phrenic nerve question? Like
I'm
previously,
so,
because he had like referred pain also in his upper arm, and the answer was
yes.
nerve as well.
He had a shortness of breath.
Yeah, shortness of breath, right?
Lung versus heart and shoulder versus arm. That's it.
Yeah,
So if
right.
you have anything related to the pleura, which is associated with the lung, it's the referred pain is just to the shoulder. That's phrenic. Now, if the question is talking about a heart attack, the classic presentation of a person coming in with a heart attack is chest pain that feels like an elephant sitting on their chest, diaphoresis, and shooting pain down the entire arm. So that's when you're thinking intercostal brachial.
Oh, thank you.
Yeah, so heart attack versus like pleurisy, something like that.
All right, so we're going to look at the cardiac cycle now. So this is the time where you kind of want to just sit down, take your time, and wrap your head around really what's going on. So anytime you hear it's systole or diastole, depending where you're from, systole and diastole. So systole is ejection, right? We're squeezing the heart. Diastole is filling, okay? So we can go through it here. Again, you can see, so during systole or during ejection of the ventricle, right? The AV valve, or let's use the left side of the heart, for example, the mitral valve has to be closed because you're pushing blood from the left ventricle to the heart, to the systemic circulation, okay? So you want the mitral valve closed, you want the aortic valve open, right? So you can eject blood. Diastole is filling. Whenever you see diastole, think of filling. How do you fill the ventricle? Well, the mitral valve has to be open and the tricuspid valve, they have to be open. Therefore, the aortic and pulmonic valve have to be closed. If the mitral valve and tricuspid valve are open, the aortic and pulmonic valves are closed and vice versa. So keep that in mind, especially when we get to the murmurs down the line. It gets a little more complicated here. So the basic premise is that when we'll use the left heart, but understand that the right heart does pretty much the same thing for this concept. So when the mitral valve opens, the blood passively goes down into the ventricle, but the last little bit of blood is going to be contracted out. So the atria is going to contract slightly before the ventricle. So you're going to get atrial contraction, then the mitral valve is going to close, and then you're going to get isovolumetric contraction. So this is the point where the heart is actually contracting, but no valves are open. Okay, the volume stays the same. And then once the pressure is high enough, then the aortic valve is going to open, and you're going to get a rapid ventricular ejection. Okay, then the same premise kind of goes in here where the aortic and pulmonic valves close. Therefore, you're going to, and at this point, at 0.5, no valves are open, right? Because it's isovolumetric. When you see isovolumetric, all the valves are closed because there's no change in volume. Okay, so you're going to have relaxation, and then the mitral valve's going to open. You're going to have ventricular filling, and then it's going to slow down, and then you're going to start the process again. So you kind of just need to go around a couple of times and kind of wrap your head around it.
One quick question.
And then, yeah, sure.
If you go back to the slide, so how come we have an increase in pressure and isovolumetric contraction and a decrease in pressure and isovolumetric relaxation since all the valves are closed?
You don't get a pressure change during that time.
I think if you, I think in the blue here,
oh,
see how there's a pressure
let's see.
increase?
It's because there's no blood in the ventricle now. So here,
yeah, I'm sorry. Yeah,
yeah, between this point and this point, it's a closed system that is full of blood, meaning you have increased pressure because you have that isometric contraction. You haven't overcome that the pressure in the aorta yet, so you're building up the pressure. Now you open the system, the ventricle is able to pump all the blood out, but once that pressure drops to a certain point and the pressure differential changes, you're closing the system again. So now you again have a closed system, but this time there's no blood in the system. So instead of building up pressure with fluid inside, trying to get that fluid out, you've emptied out everything. So think about it as a calculation. Pressure increases when you have a volume increase and a not a volume increase, but the space, it's with respect to the space and the volume. So now you've emptied it all out. There's no pressure in there. Does that make sense? Because you've closed the system and the system no longer has anything in it.
I think you're referring to the radius.
Yeah.
Right.
Yeah, look, I think I could explain it here with this. So when there's no change in volume, that means that the valves are closed, but you do get a change in pressure because the actual muscle is contracting, right? You're right, the radius is going to start to decrease because you're starting to squeeze down. But if you look here at this, the way I like to look at the pressure volume loop is, since it's pretty much a square, let's forget about this part right now, but let's act like it's a square. You have pressure on the y-axis and volume on the x-axis. So you're only changing one variable at a time. When you open the mitral valve, you're going to start filling, right? That's diastole. So you're not changing pressure here. You're just increasing volume, okay? And you can see that because the x-axis is changing, but the y-axis is not, right? So there's no change in pressure. Then after you filled the left ventricle, the mitral valve closes. And this is the point you were talking about. So the volume isn't going to change here, but yeah, the muscle is starting to contract. So you're going to get a pressure increase. The pressure is going to keep increasing until the aortic valve snaps open, right? And then at that point, you're going to get a rapid ejection here. You do get this pressure increase because you're actually continuing to contract the muscle, but then it gets to a point where the volume is decreasing, right? So we went from increasing volume only, all valves are closed, we're increasing pressure here, just pressure, only the y-axis, till we get here, the aortic valve snaps open, we're decreasing volume, right? And then here, this is that relaxation phase. So between this point here and this point here, no valves are open. The ventricle is literally just going to relax. It's going to decrease in pressure, and then the valve's going to open. So yeah, you're right. That radius technically is going to start to squeeze, but obviously much more drastically once the valve opens, because it's going to start injecting blood. Okay, let's try that. I hope that was helpful. Let's try this one. I just like to break down the PV loops as, are we talking about volume or are we talking about pressure? Are we talking about the x-axis or are we talking about the y-axis? That helps me break it down. All right, and y'all are doing good with this. So this illustrates what I was saying, right? What phase is between the aortic valve closing and the mitral valve opening? So we know we're talking about either a pressure increase or pressure decrease, because no valves are open, so you can't change the volume, right? So the point at aortic valve closes is right here. Mitral valve opens right here. So this is going to be that isovolumetric relaxation. Why? How do you know we're relaxing? Because look at this decreasing pressure. Look at this y-axis. We're going down here till it's relaxed. So that's phase 4. Now, this is so important. I want to reiterate it again. So mitral valve opens here. We're just going to change, basically just going to change the x-axis, right? So that's volume, increasing volume. Mitral valve closes. Now we're going to undergo systole. Isovolumetric contraction until snap, the aortic valve opens. Now we're going to decrease in volume, right? So that's that systole phase, right? We're decreasing, we're ejecting blood. So you get to this point, we've ejected the blood, aortic valve closes, there's no valves open right now. So we're just going to relax, right? We're going to decrease in pressure until the mitral valve opens again, and we do it all over again. Right, so make sure you understand normal before we get into abnormal. We'll do that later on. So this black is normal. And once we get valvular problems, which we'll discuss later, then we're going to get some deviations in the PV loop. All right, this is the slide. Lindsey will probably agree with me. You kind of just need to print it out. Yeah, so if you see, once you get into the EKGs, you'll add this to it. But right now you can kind of focus on the top part. The blue here is going to be pressure, as you can see over here. And down here, this pinkish purple is going to be volume, right? So you would expect with the drastic increase in pressure, you're going to get a decrease in volume. So if you just kind of trace one line in your head at a time, you can kind of work out at what phase everything happens. But this is kind of something you just need to sit with and kind of wrap your head around. But as you go on next week and you add the EKGs, it'll get a little bit easier. This is just where the valves snap open or snap closed. All right, this one's a tricky one, but go ahead and try this one. This is one of those pre-test questions that are kind of tough.
I just want to answer one of the questions in the chat really quick. Sorry to interrupt. Someone asked how they can test us related to that graph. So I went to Dr. Toledo's office hours and someone had asked the same question. So he had said that they'll test us on this graph where he can essentially put up any of those graphs. So he could only put up ventricular pressure, or he could only put up atrial pressure, or they could show the whole thing. And he said basically you need to be able to identify any of the phases, just giving a single one of those lines, whether it's the red, blue, any of those. And he said you need to be able to identify when the valves are, which valves are opening, which ones are closing, what part is systole, which part is diastole, and like identify each of the 7 phases.
Yeah, so
Great.
if you look on it real quick, you see this right here?
I can't see your mouse, Lindsey.
Oh, you can't? Oh, hold on. I will annotate. See this right here? It kind of goes to the pressure volume loop. So you see the mitral valve closes, mitral opens, aortic closes, aortic opens. So in your notes, relate this back to the PV loop so you know what's going on in the ventricles and the atria. You need to know this with respect to any pathology. So very high yield is murmurs. They can put this on here and they can alter it and ask you, give you a clinical presentation and ask you, hey, what murmur are we talking about? Or, I mean, they're going to use it to, it's going to help you find out the murmurs. Then go down here and relate it to this EKG line. So pressures, so the pressures are changing in which part of the EKG, how does that do? But you are correct, they can put something on here and you need to know, they're probably not going to test ventricular pressure because it's very, very, very obvious which one is ventricular pressure. They would probably test more the aortic or atrial pressure, in my opinion, because
yeah, he focused a lot on the aortic pressure line.
Yeah, they're probably not going to show you ventricular pressure because that's a gimme. But yeah, aortic and atrial, those are probably the best. And then kind of relating ventricular pressure to ventricular volume, that's also high yield. But I remember, and I put this in the chat, they use this a lot with the murmurs and manipulating any of the pressures and then asking what's that associated with. So if that helps you at all.
Yeah, for sure, for sure. I didn't want to get into this because y'all haven't done EKGs yet, but this QRS complex, that classic spike, it correlates to ventricular contraction. So if you just keep that in mind, then you can actually walk your way up, right? So at the point when the ventricle contracts, you're going to get mitral valve closure right before, right? Because you're going to start systole, right? You're going to start ejecting blood. So right before this little, between this thick line and this dotted line, you get this isovolumetric contraction. So the ventricle starts to contract. So you had this QRS complex, the electricity went to the ventricle. So now you get to the pressure right here where the aortic valve snaps open, you get ejection, right? And then again, you get that isovolumetric relaxation. Like Lindsey was saying, you relate this back to the PV loop. Just make note that, yeah, you could see the yellow line, obviously right before the ventricle fills, you're going to get that atrial systole. So the atria is going to have just a little bit more pressure than the ventricle. And at this point, you do want to note that the aortic pressure does rise at that isovolumetric relaxation phase, right? Because there's an increased pressure in the aorta right around that area. So yeah, that's pretty classic. And then I think the volume portion of it is pretty self-evident, right? Because if the increase in pressure and the valve's open, then you're going to get a decrease in volume, right? So then y'all will get into the EKGs. P wave correlates to the atrium. QRS is ventricular, but y'all will get to that later.
I have a really quick question on the
Yeah.
T wave. Can you go back, please? Really
Yeah,
quick?
sure.
Yeah, you see that the T wave is under the systole section, right? So,
Right.
but T wave is ventricular repolarization. So
Right.
I kind of get confused because if it's repolarization, it's not contracting at this point, right?
Right, it's relaxing.
That's the electrical impulses through the heart. That's what an EKG is. It's just the electrical impulses. So all it's doing is putting that on this graph with respect to time. So it's basically like, when this is happening, this is also happening. When this is happening, this is also happening. And so don't relate that back to contraction. It's the actual electricity through the heart. And so you guys are going to hit EKGs hard later.
Yeah, I think y'all have 2 lectures specifically on it. So y'all will talk specifically about the electrical impulse of the T wave and why the QRS complex has this variability here, or the part of it goes up and down. Y'all will get into all of that. So I wouldn't concern yourself with it right now.
Don't worry about it right now at all.
Yeah, but it's basically like Lindsey was saying, it's the electrical impulse of the repolarization. It is kind of relaxing so that it could depolarize again. All right, I'll give y'all another second. Try to answer this one if you haven't. So this is a tough question from pretest, but basically, if this thicker line or this line at the bottom is atrial pressure, at point D, the atrial pressure is higher than the ventricular pressure. So that's when you're going to get this ventricular pressure is going to increase, or the blood from the mitral valve is going to open, excuse me, and the blood from the atria is going to go to the ventricle. But the explanation is in the Socrative, and it'll be posted later. Excuse me. I put this is from first aid. So it kind of just lays it out for you a little bit better, kind of breaks it down or separates all the lines. If you don't use first aid, I always preach about it. You should definitely check it out. Excuse me. Heart sounds. I don't, this is important to know.
The previous question, please.
Yeah, sure.
What was the SID again?
Thought it would.
Okay. Yeah, so at point D, the atrial pressure is actually higher than the ventricular pressure. So you get that flood of this blood flow in here prior to the ventricular pressure increasing, or the this isovolumetric this isovolumetric contraction right about the point where the aortic valve opens. It's a tricky question. I think the explanation, I don't even know that the explanation is.
For this one, just like don't memorize the way it is. Like you need to understand how the pressure works, not just memorize the diagram as it is in the lecture. So we normally see it like up top where it starts like between the ventricular pressure where it starts the that's systole. You just gotta know like the pressures related to the pressures always.
And make note.
Go ahead.
Make note that it's pressure over time. This isn't volume.
The
I don't know if y'all.
ventricular filling supposed to be from point B to point E, and I thought rapid ventricular filling would be between point B and C, and then reduced ventricular filling would be point C to D.
No, you're gonna fill. No, so it's over time, right? So this, so you're gonna actually, the volume phase is gonna be from point B to point D. But you see this increase in atrial pressure right here from C to D. And then that's when you're gonna start, that's when you're gonna have the ventricular pressure. So just make note that it's pressure over time, not pressure over volume.
Okay.
I had a quick question regarding this. So when does isovolumetric relaxation happen? Because I thought that between B and D we would have a systole, and then right after D we would have isovolumetric relaxation and then rapid filling. So I sort of got those concepts confused.
I think it would be on the other side, right? So you would be getting a decrease in pressure. So from here to point B would be the relaxation phase, because this is from C to D, we're increasing pressure. So this is the point where you get the ventricle filling and then the pressure increase.
Oh, okay, thank you.
Yeah, no problem. It's a tricky question. Don't try not to get, yeah.
Sorry, can you hear me? I was muted.
Yes.
So
problem.
the ejection will be from D to E?
Yeah, you would get, well, yes, technically, but remember D to E is the atrial pressure. So you're getting a decrease in atrial pressure here. The graph's not great, to be honest with you. I pulled that out of pretest, but it's not great. It would have been easier if they color coded this line versus this line. Just don't get too hung up on this. I just wanted to point out that you do get a pressure versus time component versus volume.
Do you know if in the test they will actually give something like this, or the ones that are in our lecture? This is kind of
I'm sure it is confusing. I apologize for that. It'll probably be more like in lecture. I wanted to try to find an image of the Wiggers diagram, and this is the one I was able to find from pretest. Okay. So I think it'll be more like lecture. And for the PV loops, it'll be over volume, not time. All right, so let's look at the heart sounds. Obviously, S1 and S2 are normal. S3 and S4, it's not normally present to find S3, but you can see it. But S4 is always going to be pathologic. So remember, they're going to be during the diastole, right? But S3 is going to be right after S2, and S4 is going to be right before S1. This wasn't, I don't remember this being as highly tested as the murmurs, but just keep in mind
maybe
that
one question.
Yeah, S1 and S2 are going to be normal. If you hear S3 and S4, that's abnormal. I'm pretty sure I have a slide on the splitting, and we'll talk about that in a little while. But go ahead and try to answer this question. This is the last question I have, Lindsey, for this part.
Okay, cool.
I'll try to find some more information on the previous question and I'll put it in the chat in a little bit. But here, so it's a lot of words, but, and we'll get into the murmurs later, but what you want to see here is it's a high-pitched holosystolic murmur, loudest at the apex. Okay, so it's during systole, it's loudest at the apex. What do we know about the apex? That's the mitral valve. And commonly this mitral valve, which is a loud murmur, will radiate to the axilla. Okay, so what you're looking at here is a mitral regurgitation or insufficiency. Because one, it's during systole. During systole, the mitral valve is supposed to be closed. If the valve's supposed to be closed and you have a murmur, that's going to be regurgitation. We're going to touch on all that in a little bit. But here, just keep in mind that insufficiency is commonly called regurgitation. But these are some of the buzzwords you can use to remember stuff, holosystolic. But definitely make sure you remember the causes too. Rheumatic fever is a common one for mitral stenosis. Okay, if y'all have any questions, I'll turn it over to Lindsey. Y'all could put them in the chat. And I'll try to get some more information on that, that graph question I had. It's all yours.
Okay, cool.
Do I have to unshare my screen? Sorry.
When I did it, it canceled yours out, so.
Perfect.
Okay, so I'm not using Socrative. Usually I use PolEv, but because it's such a large group, it won't let me. So we're just gonna answer in the chat and talk about it. There are concepts that are overlapping with Brady, but what you should get from that is that if we both picked it out as being, high yield, you really do need to focus on it. So my questions are going to be similar, but they're going to test something a little slightly different. So hopefully you've got some concepts from his part and you can transition that to mine. I have a couple intro slides. Just make sure you don't stop with grays. From now on, you will get some assigned grays questions. This is especially helpful for embryology to figure out how they're going to test you on that. Again, exactly what Brady said, CPR is very conceptual. It's not rote memorization, and to understand one thing, you have to have understood something previously. So make sure that you are spending time on that. And then I've been preaching Ninja Nerds to you guys for CPR, but it's because I do truly believe it works. So that's the Cardiovascular Physiology playlist that you can put into a browser. I really do think it's helpful. So, okay, so you can put your answer choices in the chat and we'll talk about them. If it's a concept that Brady already has hit hard, we don't have to spend too much time on it. I do believe repetition is good, so. Okay, everyone is saying C, hypotension, and you are absolutely correct. This is pretty much pretty much the same thing he showed you, Beck's triad. What this means is you really need to know what the presentation is, because this can be a really easy question if you are familiar with the presentation. So they could ask it in any sort of way. They could ask you, where's fluid accumulating? They could ask you how I did, what other signs are you going to see? They could give you the clinical presentation and say, okay, where would you drain this fluid? So there are many different questions that they could relate it back to. So, and they could also, these are all my notes, so I have highlights and I bring in stuff from the internet. So the fibrous layer is stiff, won't expand, so compression and increased pressure. So this is just something that I put in there that I thought would help me understand this concept. Yes, everyone is saying D, and that is the correct answer. You do need to know these. Brady related this back to also being able to identify murmurs. That is something that they could do. I would be aware of valve location versus auscultation, but they will most likely ask you where you're going to auscultate certain valves. We're saying E, that is correct. Real quick, what type of vessel are we looking at? Your choices are muscular, elastic, yes. So you need to know, so this is made up of 40 to 70 layers. I would familiarize yourself with the different numbers of layers because they can test you on that. Know the different characteristics, know what type of tissue they're made up of. But more important than that, you need to know the big characteristics. So you could get a question like this. You probably will get a question like this, where you have a clinical presentation and they say, which of the following arteries is affected? And they're going to give you a big, the answer choices like this, and they'll label it and you'll have to identify between them. So make sure you can identify. So you can just name the artery. You don't have to say which one of these, but which one is responsible for changes in blood pressure? This is extremely high yield and they will ask it on your test.
First picture to the left.
Arterial, yes.
Arterioles.
It is the arterioles. How do I know this was the elastic artery? Because of the picture, honestly. So you have the elastic up here, and just memorize this picture. Yeah, the fibers, the elastic fibers. So memorize these pictures, and you can see this stain. This is staining the fibers. But so which is likely affected in Marfan syndrome and why? Yeah, elastic is the fourth one. Elastic, yes, because it's the elastic fibers, and that's what Marfan syndrome is going to affect. Real quick, let's go back to the arterioles. Which one, 1, 2, 3, 4 is the arteriole? 1, exactly. And then you don't have to answer this. This is just for your own edification and study purposes. How many layers do each contain? So just make sure that you are able to pick these out of a lineup without being labeled and describe all of them.
The second one would be a muscular artery, and then the third one would be a small artery?
Yes, you are correct.
Thank you.
So arterial, muscular, small, and then elastic. The elastic are the big named arteries. So
I had a quick question for the small arteries versus arterioles. What's the biggest difference, like for movement of the blood?
Small arterioles, they don't actually say a whole lot about them. The arterioles are going to regulate blood pressure because they are like the constriction and dilation.
High resistance.
Okay, thank you.
Yeah. Okay, so we have one guess for fenestrated. Multiple guesses for fenestrated. You are correct. So I told you this guy has end-stage renal disease. So that should automatically tell you that you're in the kidney. You need to know the difference between these, and you need to know where they are located. That can be like 1 or 2 easy points on your exam if you know where all of these are located. Brady talked about one of his questions. It was the fenestrations, and then on the basal lamina, you do need to know that. So discontinuous has a discontinuous basal lamina. You need to know what size are going to pass through all of these, if any. Continuous, you have uninterrupted endothelium, tight junctions, everything. So make sure you know the difference between all of those.
Will they ever say like discontinuous endothelium to like try and trick us?
Discontinuous endothelium. I don't think so, because an endothelial cell is what lines the capillaries. And so it would be, I don't know. They might just say discontinuous or sinusoidal capillary.
Yeah, I would agree. I would say that. That's what they would say.
Yeah. So we have A and C, so we're between superior and anterior mediastinum. Does anybody have anything different? Do we agree, disagree? So we're talking about the thymus, thymectomy. It's actually the superior mediastinum, most of the organ. So when I was going through the notes, I made sure to make my question reflect most of the organ. There is some of the organ that extends into the different part of the mediastinum, but most of it is going to be the superior mediastinum. Yeah, that's most of it.
Do we actually need to memorize all those different like organs in different parts of the mediastinum?
Yes, you do. Anterior penetrating wound, we're saying right ventricle, and you are correct. It is the right ventricle. You do need to know these pathologies. They will probably ask about the right ventricle and the left atrium. So you need to know this. You need to know that sharp swallowed objects will be the left atrium. Anything that is associated with dysphagia, you're talking about the left atrium. So you need to know these relationships. Why? Because the heart is kind of on a tilt. And so the right ventricle is very anterior. And so if you get a penetrating wound, you're going to damage this right ventricle. The left ventricle is kind of set posterior, and there's a lot going on here. So the first chamber you're going to hit is the right ventricle. And then you see the relationship of the esophagus with the left atrium. Remember, anatomy-wise, all of this stuff, it's all about relationships. I got a question earlier in the chat about the imaging images that they put in your slides, and do we need to memorize that? Well, yes and no. They're giving you multiple cuts. The important thing and the easiest way to remember those is the relationships of structures with other structures. So if you know that the left atrium is anterior to the esophagus, you can kind of pick it out. And then you see this big vessel right here. So you need just remember the relationships, go through all of those images, follow the different structures down those images. So you're not memorizing all of the labels, but you're orienting yourself to the relationships of all of the structure within the thorax. That's going to be the easiest way for you to remember all of those. Yeah. So AV bundle is the answer. You need to know the territories. Brady went over this as well. You need to know the branches. You need to know the territories of the branches, and then the territories of the main arteries. Because if you ligate, or if there's a blockage in any one of these, anything downstream is going to be affected. So you do need to know the territories of all of these. Yeah. So we are talking about ejection fraction here. This is very common. If you talk to a patient with heart failure, they probably know what their ejection fraction is if you ask them. And so that is going to be your best indicator of progression of the disease, but also effectiveness of the treatment. So ejection fraction is essentially the fraction of the blood being pushed out of the heart, which is kind of a measure of the effectiveness or contractility of the heart. Whereas stroke volume, it's simply a measure of the blood coming out. And then cardiac output is, I forget what Somebody put the equation, cardiac output, what is it?
Stroke volume times heart rate.
Yes. Stroke volume times heart rate. So that's basically the output of the heart over a period of time. So this is one pump. This is over a period of time. Ejection fraction is the effectiveness of that heart pump, if that makes sense. But you need to know all of these concepts inside and out, FYI. Every single one of those terms you need to know like the back of your hand. So we've talked about this multiple times. I hope you guys understand this now. Yes, intercostal brachial nerve. So again, phrenic, lungs to the shoulder. Intercostal brachial, heart to the entire arm. So make sure those two clinical presentations are understood. So prior to arrival, that's what that means. We're going to go over a lot of embryo in a bit too. So if that's confusing to you. Yeah, D, right truncus arteriosus. You gotta know this stuff. You'll get a handful of questions on the exam about this. On the CPR1 review I gave you, I condensed all of this information into one little space because they have a lot of slides that explain just this. So, but you do need to know that, make sure that you understand that it's left versus right. But you'll get a couple questions on that. Yeah, B, PDA. This is a really common, Down syndrome is actually associated with a lot of the birth defects that are discussed in your embryology lectures. So make sure that you familiarize yourself with all of the defects. DeGeorge is one that they associate with one. Make sure you know Tetralogy of Fallot really well. That's a really big one that they'll ask you about a couple of times, not just once. They'll ask you about Tetralogy of Fallot a couple of times. So this is due to 3 months of dyspnea, shortness of breath, on exertion. Yeah, top left. So what are we talking about here? What kind of murmur is this? Aortic stenosis, yes. So this is a way they could ask this question. They could give you a presentation. They're not going to diagnose this patient, and then they're going to give you either PV loop. They could give you the Wiggers diagram. They can also give you the phonogram or whatever that thing is called with the heart sounds. So all of those things you need to be familiar with. So this is aortic stenosis. So again, they can give you the heart sounds, they can give you the Wiggers, they can give you the PV loop, any of these. Also, I want to make sure you guys understand this. They don't have to give you the buzzwords. So the buzzword for this is crescendo, decrescendo. They're not guaranteed to give you the buzzwords. I remember a couple of those questions. They didn't give any buzzwords. It was all the other stuff that you could say those are buzzwords, but crescendo, decrescendo is kind of the big one that people look for. But make sure that you can recognize these murmurs without being given those buzzwords, because they can give you anything else about it. Another thing, dyspnea on exertion, chest pain on exertion, and syncope is the classic triad of aortic stenosis. So if you see those three symptoms, you can safely say it's aortic stenosis. So
if you don't mind, can you like go more in depth about like the stenosis?
Go in depth with the stenosis?
Yeah, how do we know if it's an aortic stenosis or mitral stenosis?
Okay, so with respect to my question stem, we'll do it that way. A low intensity S2 is characteristic of aortic stenosis. I also told you that it's a crescendo decrescendo systolic murmur. That's also characteristic of aortic stenosis. And then I gave you the classic triad. So there are 3 characteristics of aortic stenosis that could have helped you diagnose aortic stenosis. And then you have to know, okay, what does the PV loop look like? And what does the Wiggers look like? And then the sounds look like. So that's how you got to approach this. You really do need to know essentially everything they tell you about the murmurs so that you can pick it out of the clinical presentations. Does that make sense?
Yeah.
So this is exactly what I just said. Make sure you know pretty much everything about them. And if they don't diagnose the patient for you and they just give you a Wiggers or they give you a PV loop, that you can still identify the. Okay, so we're gonna hit the PV loop hard again, because like Brady said, this is very, very, very high yield. Very high yield. You need to understand this. This is one of those things that you really need to conceptualize early on. So we're saying Y is pressure, X is volume, which is absolutely correct. You can use the letters designation. Yep. And diastolic is C and systolic is A. Where does the aortic valve close? Yep. Yep. And then of course the last one, the aortic valve is now opening. Now, where are S1 and S2 heart sounds? Yeah, C and F. Think of it when a valve closes, that's the sound you're actually hearing. So now calculate stroke volume for me. Yep, how do you get stroke volume? Yep, EDV minus ESV. So if they give you a PV loop, they can ask you to calculate stroke volume. That'll probably get you a point on the test. So make sure that you do understand that. So does everybody understand this? You need to know this graph like the back of your hand. You really need to know this like the back of your hand. So Brady went over it. I just went over it. Okay. So that's the answer. YouTube, this is the cardiac cycle one. I posted it in the chat. That's the end of mine. I just went through it really quickly. Brady, did you say you wanted to go over embryo? Real quick.
Yeah, sure. I can go through the rest of my slides. I don't have questions for him, but yeah, we definitely can. Yeah, I posted the links to the questions. Do y'all want a 5-minute break or something? Do you want us to keep going?
5 minutes will be nice.
Yeah. All right, cool. So it's 11:48. We'll start here. We'll start at 55. Okay.
So what will they build on in the coming week? I think what you're asking is stuff from the previous. It's a question in the chat.
They'll definitely do, you're going to do EKGs. And what's tough about that is you're going to learn the different leads. I always find that confusing, and the polarity and the vector formation of how all the, on the EKG, whether
I only
the values
remember
go up or
like
down.
3 EKG questions on our exam. It was not that high
Yeah.
yield at all.
Yeah.
And there are 2 really long lectures over it too. And so
Yeah.
it's very deceptive. You think you have to know EKGs in and out like a cardiologist, and then you get to an exam, it's like 3 questions. It's like, okay, come on.
I think one of the saving grace was that we did, because being that we took the test online, we didn't have a whiteboard to actually do the EKG. You do it on like a circle, the mean axis. And so you figure out if the patient has a left axis deviation or a right axis. But if you have to do it in your head, it makes it really confusing. So I think our saving grace and your saving grace may be that they understand you don't have scratch paper, so you won't have to do those problems. They'll make them a little bit easier. The ones they gave us, you were able to do in your head. So.
It wasn't that bad at all. Yeah, there was one where we had to do the vectors, and then 2 over EKG blocks. So you had to identify the block.
Yeah, I think this week will be a little bit more math heavy when you do stuff too with all the equations, central venous pressures and all that.
Brady, will you be going over the septal defects as well?
Yeah, we'll do those. Okay. Yeah.
So I got a request to go over my second to last question real quick.
Oh, you could share your screen if you want.
So if we're talking about, aortic stenosis. So let's go through the answer choices. So we know this one is aortic stenosis. What is this one going to be? Mitral stenosis, okay. What about this one? Aortic regurgitation, okay. And then yes.
Isn't the last one aortic regurgitation?
Hold on, I'm gonna pull up my come on. Nope, come on.
That's right. The bottom right one should be aortic regurgitation.
Okay, here we go.
I'm gonna cover all this too again in detail. I pulled it from first aid.
So I pulled all of the stuff here. This is in the review I put on there. So the distinguishing characteristics. So first you need to know systolic versus diastolic, because that's going to narrow it down 50-50. They will probably tell you in the question stem that they hear a diastolic versus a systolic murmur. So if you do get that distinction, you've already narrowed it down. So I would know what the systolic versus diastolic. Now look at the buzzwords. Aortic stenosis is crescendo, decrescendo. Mitral regurg is panhystolic or holosystolic. Aortic regurg is decrescendo or high-pitched blowing. So those are your buzzwords. But remember, they might not give you buzzwords, so don't count on that being there. So with respect to associated pathologies, remember the triad for aortic stenosis. Mitral regurg is associated with post-MI, so after a heart attack. Aortic regurg says aortic root dilatation endocarditis. Mitral stenosis is a sequelae of rheumatic fever, so it's something that can occur after it. So that can also give you a clue, because in the question stem, they might say they have a history of rheumatic fever, and so you automatically are thinking mitral stenosis. You also need to know the sounds. So aortic stenosis, you have a decreased S2 intensity. Mitral regurg, I didn't put it on here. But mitral stenosis, diastolic sound between S1 and S2. So that's important. And then the pictures. These are huge. You need to be able to distinguish the PV loops and the Wiggers. That is important. They'll give you a lot of questions over this in ESOFT and IMCQs.
Yeah, worst case, just memorize them, but we're going to talk through like why the loops change in a little bit. I guess we could go ahead and I'm sure everybody's ready. Let's see. All right. So I went through the heart embryo stuff. Again, embryo is like it's previously been. It's, you know, it's important. You want to kind of get the buzzwords down, but by far the most high yield stuff is the clinical applications for it. But don't look over it. So some of the things you want to take note of are the formation of, you know, how it forms this this tubular heart first, right? So all these are buzzwords for you. So what do they turn into? First, before that, remember that this heart tube comes from lateral plate mesoderm. Lateral plate is what you're going to want to remember there. Okay, so I put this in here. Just memorize this table and you should be good. You can know what turns into what embryologically. One of the things I don't want you to get confused about. Okay, so let's look at these pictures real quick. First, dextrocardia, the L in L loop doesn't mean left, okay? Which is confusing because the L loop means the heart is positioned on the right. So if it undergoes the L loop, the heart is going to be on the right. So don't get, and the D loop means the heart is on the left. So don't get your D's and L's confused because D doesn't mean dextrocardia and L doesn't mean left. L means heart's on the right. D loop means it's normal. Okay. For some reason, I remember getting tripped up on a test about that. Anyway, so let's look at this. So we're looking for the apex of the heart, right? So both hearts, the apex is on the right. So what's the difference here? So if you could, what the distinguishing characteristic, for me at least, is if you find this gas bubble in the stomach, that gives it away, right? So the stomach should be on the left side, right? So this one's dextrocardia, just the heart. The heart undergoes the L loop, meaning the apex is on the right. Here you can see that the gas bubble's on the right with the heart. So that's sinus inversus. So when in doubt, if you're trying to figure out if it's sinus inversus or not, find the gas bubble. The liver's dense, right? So, okay. So for the first embryo lecture, I think by far the most important part is the atrioseptal defects. And so I put it here, make sure you know these atrioseptal defects, there are 5. Basically, if you can give a definition for them, I mean, it'd be great if you could break it all down, but at the end of the day, if you have a definition for each of these, a patent foramen ovale, you'll be fine, right? So the ostium secundum type, the secundum comes after the primum. It gets confusing. You can watch it a couple times and still be confused. So at the end of the day, I think you'd be okay as long as you have a solid definition for each of the different defects. Okay, so the ventricle similar. If you have problems with ventricular, the septum forming, you can end up with a VSD or a ventricular septal defect. As Lindsey mentioned, Down syndrome is associated with a lot of problems, but when you talk about endocardial cushion defects, it's often a Down syndrome problem. So whereas Down syndrome can be a VSD, a ASD, and endocardial cushions, typically if you talk about endocardial cushions, they'd be discussing Down syndrome. The endocardial cushion is basically that septum right in between everything, right? It's gonna separate your atrium and your ventricles and the AV valves. So yeah, let's see. Just put this in here. When in doubt, always select neural crest cells. There are 3 components that you want to remember that the neural crests are involved in: the truncus arteriosus, the aortic and pulmonary trunk. This comes in when we talk about one of the defects that forms the membranous intraventricular septum and the partitioning of the bulbous cordus. Okay, so we'll talk about that in a second when we get to the pathological problems. All right, this is always difficult. I'm going to try to walk you through it. Just remember for the aortic arches, like first is maxillary, second is for the stapes. The ones you need to worry about, third, common carotid, right? Fourth is going to be on the left side, you're going to get the arch. On the right side, you're going to get the subclavian. And then 6 will be the pulmonary system, the pulmonary arteries, ductus arteriosus. So you kind of walk your way down, right? You're kind of in the neck here, aortic arch, and then the pulmonary arteries. I think, oh yeah, I put this here. So by all means, 3rd, 4th, and 6th are what you're going to need to know. Okay, so this is what I want you to do. If you see my cursor here, you see this purple heart, okay, right here? I want you to snap a picture right now of it in your head. And I want you to remember that if we're looking at the patient, this is the right dorsal aorta, the right distal dorsal aorta, this little part. So if you snap a picture, we know that normally this little part is supposed to involute or disappear, right? Okay, that's normal. Now, involution of the distal right dorsal aorta. Now, double arch syndrome, if we remember our picture, this didn't involute, right? So this stayed. So when you get a double aortic arch, the problem is when this stays, the aorta forms like, it surrounds the trachea and the esophagus. So you can imagine clinically, the patient's gonna come in, if you have vessels surrounding your trachea and your esophagus, you're gonna have trouble breathing, the child's gonna have trouble swallowing, and this is gonna be due to the compression. So by definition, we wanna remember double aortic arch is persistent of that distal right dorsal aorta. Okay, now remember our picture we took? This is supposed to involute. Instead of this involuting, the left distal dorsal aorta involutes. Now what this means is instead of the right involuting, the left involutes, you're gonna get this right aortic arch, right? It's gonna be on the right side, just because of the situation here. There are different variations of it, but I think you're good if you know that it's going to be on the right side, right? So the left side involutes opposed to the right. We have the definition here. When in doubt, if you know the definitions, you should be good. Okay, and then lastly, if we look at this one, remember our heart, this one's supposed to involute this part, but instead the right proximal dorsal aorta involutes. Now the problem here is the right subclavian is supposed to come from this part, and since it involutes, the right subclavian has to come from the left side and loop around to the right. Okay, so that's going to be this right subclavian from the other side. So if in doubt, just remember these, but picturing what's supposed to happen and then looking at the differences helped me wrap my head around what happens in the adult form. Okay, so if we look here, remember this 4th arch. What we want to talk about in regards to that, and we had a question earlier, is in regards to the recurrent laryngeal nerve. So remember on the left side, the vagus nerve is going to give a branch that's going to loop around the aortic arch on the left. That's the recurrent laryngeal. Remember, if you have swelling of the aorta in that area, you can get dysphagia. Or I'm sorry, you get hoarseness, right? Because the recurrent laryngeal gives branches to the larynx. So if you compress that, you can get hoarseness. On the right side, remember the recurrent laryngeal is going to go around the right subclavian. Put the picture here, you can see here, embryologically, that's how it forms. So they loop around. On the left, it's the aorta. On the right, it's the subclavian. Okay, fetal circulation. Right, so a couple of things. So the ductus venosus, the point is you want to bypass the fetal liver. It's not fully developed, and it's the placenta and the mom's job to detoxify everything. So ideally, we want to we shunt blood away from the liver. Don't want to use the fetal liver. Also, probably more importantly, is the fetal lungs haven't developed. You'll learn that part of the development of the fetal lungs is that the fetus has to swallow a lot of amniotic fluid. And by doing that, there's fluid that gets into the lungs and it helps to develop the lungs. Point being, you don't want blood going to the fetal lungs. You can't oxygenate it. It's the mom's job to oxygenate the blood. So the point of the foramen ovale and the ductus arteriosus is, by all means, we don't want blood going to the lungs. You can't oxygenate it. So one of the things embryologically is that the vessels in the lungs are severely vasoconstricted. It's a high pressure system. Blood's going to go from high pressure to low pressure, so it's going to avoid the pathway to the lungs. Now, if we, let's see, I put this in here from first aid. I just thought it was a little bit better of a picture, but right, let's go back to this real quick. So the foramen ovale is going to be a hole, a foramen, in between the two atria. The point being, going from a high pressure system to a low pressure system, in the fetus, you're going to go from the right side to the left, which is perfect because the right side is supposed to go to the lungs. We don't want it to, so we want to shunt blood from the right atrium to the left atrium. Perfect. Ductus arteriosus, well, you could say, well, what happens if some blood gets into the right ventricle? Then what? Well, it's actually going to go into the pulmonary arteries, but there's the ductus arteriosus there. And what that does is it connects the pulmonary arteries to the aorta, all right? So it's, instead of going from the pulmonary arteries to the lungs, the ductus arteriosus is going to let it go to the aorta, to the left side, right? Because it's already oxygenated from the mom, so you want it to go to the systemic circulation, right? So this is important because we want blood to not go to the lungs. The right side of the fetus, the right heart, has increased pressure. The lungs are very vasoconstricted. Okay, so any sort of shunt we have is going to go from the right side to the left side. That's what we want. After birth, when the baby takes its first breath of air, the vessels in the lungs dilate and you get a switch. And then the left-sided pressure is greater than the right side. And that's what you want because that actually closes these foramen and it allows this basically all the shunts to close in the heart. So we'll discuss that in a little bit more detail. So like I said, the foramen ovale separates the atria. So what happens is here you can see a picture of it. So so when the fetus has increased pressure in the right, it's going to shunt blood to the left side, which is good because the mom oxygenated it. You don't want it to go to the lungs, so it's going to go to the left side. The ductus are okay. So one more thing. When the baby takes its first deep breath in and the shunt is switched, or not the shunt, but the pressure is switched where left atrium has a higher pressure or the left heart has higher pressure than the right heart, it's going to cause this valve to close. Okay, so then there'd be no more shunting of blood. Whereas the ductus arteriosus, similarly, I think I have a picture. Yeah, look here. So the ductus arteriosus, like I said, if it goes from the right ventricle to the pulmonary arteries, you don't want it to go to the lungs. So instead, this ductus arteriosus allows it to go to the systemic circulation. So what happens here, the closure is similar. It's not the actual act of taking a deep breath in, but it's the act of the increase in oxygen to the baby. That's going to decrease your prostaglandin levels. And by having decreased prostaglandins, that will close the ductus arteriosus. I have a slide just to reiterate that in a second. Okay, so yeah, so for the ductus arteriosus, if you have a problem with the baby, like some sort of Tetralogy of Fallot or whatnot, you may want to keep the shunt open temporarily. Okay, so you can give the baby prostaglandins. That'll keep the ductus arteriosus open. Like I said, the increased oxygen will decrease prostaglandin levels and it'll close it physiologically. You can also give indomethacin if you want the ductus arteriosus to close. Indomethacin is an NSAID, a non-steroidal anti-inflammatory drug, and NSAIDs act to inhibit prostaglandins, so that makes sense, right? You give indomethacin, it'll counteract prostaglandins. Okay, so we kind of talked about this. Most important, the entry of air into the lungs, that's going to close your foraminal valley. Increased oxygen is going to decrease your prostaglandins and eventually close the ductus arteriosus. All right, this is a little bit more of the same. The ductus venosum for the to bypass the liver closes a little bit later, but pretty much we talked about all this. Okay, this is one of the problems, and this is a classic scenario. This is a classic question they can ask that's pretty straightforward because the symptoms are classic for coarctation of the aorta. So what happens, a coarctation, these are two arcs basically, right? It's a pinch point. So what that means is when blood's coming here, it's going to be compressed here, or the pressure is going to increase. So it's going to want to be diverted to other places because of the increased pressure right there. So first things first, if they say Turner syndrome, that's classic for coarctation of the aorta. Secondly, if you have this pinch point here, what's going to happen is you're going to shunt blood away from that pinch point from the subclavian into the intercostals, okay? And then it'll get down to the descending aorta. So if you think about it, let's see, okay, first, by shunting blood to these intercostals, you get this classic thing called rib notching, okay? So if you hear rib notching, that means you're using collaterals and you're causing that increase in blood is going to cause what's defined as rib notching, which is where these intercostals run on the inferior aspect of the ribs. Right, so clinically, this is what you're going to see. Since the pinch point is after these vessels go to the upper limb. This pinch point is after that, and it correlates to the blood going to the lower limb. So what that means is if you take the radial pulse versus the femoral pulse in the child, there'll be a difference there. That's because of this pressure point, right? Blood is getting easier, getting to the upper limb easier than it is to the lower limb. So classic, if you see that, you're thinking coarcation. Rib notching, enlarged collaterals, which will cause the rib notching, and cardiomegaly. You get cardiomegaly just because of the pressure on the heart. You're not able to pump blood properly. But if you also see, it makes sense, underdeveloped lower extremities, right? Because you're not getting proper blood flow. So you get this differential between upper limbs and lower limbs. One of the managements is to give prostaglandins. We just talked about, the prostaglandins will help keeping the ductus arteriosus open. So let me just show you this real quick. If you had a coarcation there, right? So the blood flow to the lower limb is impeded. If you're able to give prostaglandins and keep this PDA open, even though some of the blood is going to be deoxygenated, at least you're getting blood to the lower extremities. So that's one of the clinical applications you can use for these patients until you can surgically repair the coarcation. Okay, let's do left to right shunts. So left to right shunts tend to be better than right to left shunts because you're shunting oxygenated blood from the left side to the right side. So at least there's oxygen involved. So these patients tend to be, or these kids tend to be acyanotic. They're not deficient in oxygen. Okay, so these are pretty straightforward shunts because the left side in an adult has more pressure than the right side. And if we break it down like I talked about earlier, the pump has two different systems. So you have the left system, the left heart, and the right system. The left heart is a lot stronger than the right heart. It's a lot more muscular because it has to pump blood to the systemic system. The right heart is a bit more delicate because you want the blood flow to the lungs to be less. And the way I think about it is, if you get blood to the lungs, there's tons of branch points. It's like a big river breaking down into smaller rivers, into little streams. So you get the same amount of water in the streams or the same amount of blood in the vessels just because of the branch points. That being said, this is why the left heart is stronger than the right heart. So typical, just simple defects, septal defects will cause this shunting. And you would expect it because being that the left heart is stronger than the right, blood is going to be shunted from the left side to the right side. Again, the blood on the left side is oxygenated. So that's definitely better than having a right to left shunt. So the typical shunts you're going to think about with left to right are your just classic atrial septal defects and ventricular septal defects. Also, a patent ductus arteriosus will be classic as well. These children can get hypoxia, but like we said earlier, you can give indomethacin, and that'll actually decrease the prostaglandins to close the PDA. Just one of the buzzwords, maternal rubella is common for a PDA. And one of the things you want to remember, another buzzword for PDAs is a machine-like murmur. It's constant, so it's not holosystolic, it's systolic and diastolic, a machine-like murmur all the way through. Okay, this is a super important point. When you have a left to right shunt, right, the left side stronger than the right side. So eventually you're going to strengthen the muscles on the right side to be stronger than the left side. And this is called Eisenmenger syndrome, and it's a reversal of the shunt. So eventually that left to right shunt is going to build up strength in the right side, and eventually you get a reversal of the shunt. So it goes from a left to right to a right to left. So you'll see classically this late cyanosis, as in the kid was okay with the left to right shunt because the blood was oxygenated, but then all of a sudden when the right heart got strong enough and reversed the shunt, then you're sending deoxygenated blood to the left side and to the systemic circulation. All right, that being said, these right...
Sorry, so sorry. Yep. I was wondering if I could bother you with a question.
Go for it.
It might be a little stupid, so I'm sorry.
No worries, come on.
So you talked about earlier how, like, when you going from a fetal to a neonate, you have that shift in pressure from right to left. I kind of get confused because in another lecture, it was so the left then has a higher pressure, which is consistent with how in adulthood you normally have lower ventricular pressure in the right ventricle. Is that correct?
That's right. But I think the better way of thinking of it, the left side kind of stays the same. The right side has a drastic decrease in pressure. And the reason is when the baby takes its first breath in, the lungs just literally open up. It's like a vacuum, right? So you went from this high pressure system not wanting blood to get into the lungs to all of a sudden everything opens up. And just the act of taking a deep breath in is a vacuum for the blood. So that's that physiological shift from a right to left to a left to right.
Okay, thank you so much. Sorry about that. I didn't mean to cut you off.
No worries. Okay, so these right to left shunts they tend to be worse. And if you think about it, to have a right to left shunt, you have to have a lot of, it can't just be a simple septal defect, like a ventricular VSD or something like that. So what happens are these right to left shunts, what you can remember are the terrible T's, right? So the truncus arteriosus, transposition of the great vessels, tricuspid atresia, and TAP-VR, our total anomalous pulmonary venous return. And what's not there is actually, what's it called? Tetralogy of Fallot. That's the fifth one. So add that there too. So yeah, so when you have a right to left shunt, this blood from the right side, this deoxygenated blood is going to the left. That's a problem because then you're sending deoxygenated blood to the left side to the systemic circulation, right? So these kids are going to be cyanotic. They're going to be bluish discoloration, right? So you're going to get cyanosis, early cyanosis. All right. So probably the one they talk about the most is this tetralogy of Fallot. Tetralogy meaning four anatomical problems end up causing this right to left shunt. Okay. So first off, you have pulmonary stenosis. You could understand that. Well, that's going to make sending blood to the pulmonary system or the right side difficult. Okay. Right ventricular hypertrophy. The right side stronger. All right, that'll promote a right to left. VSD, that's the hole we have to send it to the left side, and then overriding aorta, which kind of makes it like it's kind of this perfect storm of a situation to allow for this right to left shunt. So you will see this classic. You want to remember these four, and it's classic for tetralogy of Fallot. What you'll see is they get what's called these TET spells. So with vigorous crying, they're obviously not breathing properly. And if anyone needs to breathe more vigorously, it would be someone with a right to left shunt, right? Because you want to get as much oxygen as possible. So if they're crying and they're not breathing properly, you can get cyanosis. What's interesting is for these kids, and they do it, obviously they end up doing it because it feels better, not knowing the actual pathology or the physiology behind it, but these kids will end up squatting. And what that does is it actually increases pulmonary venous return to the heart. So you're actually increasing the pressure that's going to the heart, which will help to negate that right to left shunt. And the three diseases that you want to remember for tetralogy of Fallot is DeGeorge syndrome, Down syndrome, and fetal alcohol syndrome. All right, persistent truncus arteriosus. This is, remember I mentioned earlier, the neural crest cells. Well, the neural crest cells help to put that septum there in between the aortic pulmonary septum. So if you don't have that septum there, you're basically sending a mixture of deoxygenated and oxygenated blood into this single tube, and it's kind of diverting whichever way is possible, right, from the aorta or the pulmonary system. Okay, you commonly see this in DeGeorge syndrome. Remember that catch-22 system or syndrome, that microdeletion on chromosome 22. Transposition of the great vessels. So this one's a huge problem, because what happens is if you think about it, if you transpose the great vessels, you get two completely separate circuits. Okay, so the left ventricle is going to go to the pulmonary system, and it's going to end up going to the left atrium, right? So the left side's completely closed, and the right side's going to go to the aorta and back to the right atrium. So you get two completely closed circuits, one deoxygenated, one oxygenated. The point being, you're not getting any oxygen to the lower or to the systemic circulation. So you get severe cyanosis. It's severe. It's immediately lethal unless you have some sort of defect, right? So you need, whether it's surgically or pathologically, you need to have some sort of defect in order to get oxygenated blood. And then even so, it's difficult for the baby to survive. You want to remember a buzzword here, this transposition of the great vessels commonly correlates with maternal diabetes. All right, so this total anomalous pulmonary venous return basically just means that the pulmonary veins kind of go to different places. You can have to the superior vena cava in different places, but the point is you're basically putting deoxygenated blood into the left side, which you don't want. Okay, so you get this severe cyanosis. Again, you need an ASD, VSD, or PDA to exist to where you can get blood or oxygenated blood to the left side so you can get it to the body. All right, so heart is a pump. I know this was a little tricky, but we're going to try to break it down for you guys. So as you remember from the end of MSK, we talked about this length tension relationship. So the more fiber length you get, or the more stretching of the fibers, the more contraction you'll get. That's pretty straightforward. But what I really want to do is break down these three different concepts: preload, afterload, and then contractility or inotropic. Okay, so first is preload. So Frank Starling's law is pretty straightforward. it kind of says that this fiber length is going to correlate to how much contraction you have, right? So the important thing is in diastolic volume is going to be, so diastole is filling, end of filling volume. So that's the point of you have the most blood in the ventricle, right? So that correlates to preload. If you increase the blood at the end of filling, that's an increase in preload. Your preload is basically how much blood you can put in the ventricle, right? So these correlate with stroke volume. Makes sense. If I increase the filling, I'm increasing the preload on the heart right before contraction. And when I do contract, that's going to increase stroke volume. So preload is basically saying how much blood do you have in the ventricle, okay? So now we can talk about afterload. Afterload counteracts preload. So afterload is that pressure you have to push against, okay? So whether it's aortic pressure or the arterial pressure or the vascular pressure or total peripheral resistance or your blood pressure, that's what you actually have to press against. So if you're severely vasoconstricted, your afterload is going to be increased, right? So your heart's squeezing preload and it has to press against the counteracting afterload to get blood to flow unidirectionally. Another cause is, so whether it's the vasculature you're pushing blood against or a stenotic valve, you're still increasing the pressure you have to push to get through, to get blood going to the systemic circulation. So just remember, so afterload's a bad thing in a if it's too high, because if you have aortic stenosis, your heart has to work harder. So therefore, the muscle is going to get bigger and then the chamber is going to get smaller. So you want to decrease afterload, you want to decrease high blood pressure, so the heart doesn't have to work so much. This is a little bit more of it if you do have a stenosis. So you got all this preload here, you're trying to press it against, and you're fighting against this afterload, this constriction here. Okay, and then contractility or inotropism. Basically, it means you're increasing contractility. So you're not changing preload. You're not changing the amount of blood you're actually putting in the ventricle. You're just increasing the sheer amount of squeezing of the heart, okay? So how would this affect your end diastolic volume? If I increase contractility?
It would just increase the the stroke volume due to pushing, right?
Yeah, it would, right? So what I wanted to make a point of is saying your end diastolic volume or your preload isn't going to change. But what about the end systolic volume?
That will change.
Right, it'll decrease, right? Because end systolic volume is how much blood is actually left in the heart after you squeeze. Well, if I squeeze it harder and increase contractility, I'm going to take more blood out of the heart. So even though the preload or the end diastolic volume is the same, if we squeeze the heart harder, we're going to get more blood out. So you're going to decrease the end systolic volume. Okay, and so this is just, if you can walk through this, you remember the beta receptors or beta 1 receptors is going to increase your contractility. So by doing that, increasing calcium, increasing force of contracting, and like you said, we're going to increase our stroke volume. So some of the positive inotropes, meaning they increase contractility, are here, dobutamine, but the big one is digoxin. So when we talk about that, I think y'all did it in MSK. So it directly inhibits sodium potassium ATPase. So that'll indirectly help you store more calcium in the sarcoplasmic reticulum. If you have more calcium, when it's time to contract the heart and you release more calcium, you're going to be able to contract it harder. So that's the point of digoxin. You want to store up this calcium there, so when you want to contract, you have more calcium available for increased contraction. Negative inotropes, you're going to think about your beta blockers primarily. Obviously, a calcium channel blocker will work as well, right? Because it's kind of converse to digoxin. If you block the calcium, you're going to decrease contractility. And I like this image. It kind of puts everything together. So this filling pressure or preload, right? How much blood you actually have there is going to counteract your afterload or this opposing pressure. And then contractility is kind of going to work with preload with let's get some blood out, right? So preload and contractility are going to counteract this this afterload or this total peripheral resistance. All right, and this is just kind of a summary. So now we kind of touched on this. So if we're increasing preload and we look at our pressure volume loop, obviously preload is volume. So we're basically increasing our end diastolic volume. So just make a note of this. If we increase our end diastolic volume, we're increasing our preload. So when we contract, there's more blood to contract. So we're increasing stroke volume. Okay. More blood means higher end diastolic volume. If we increase contractility, like we said earlier, we're actually going to decrease our end systolic volume. Like we said, we're not changing our end diastolic volume or our preload. Okay, we're just squeezing harder in order to get more blood out. Okay.
Just one quick question.
Yeah.
How is ESPVR related to contractility?
Directly, because if you increase contractility, you're going to increase the pressure, so you're going to decrease the volume.
Thank you.
Yep. Okay, and then afterload, like we said, it's opposite, right? So we're pressing against it. So you do have a slight increase in end diastolic volume, but the point I want to make is if you're increasing the pressure that you have to press against, like your blood pressure or the total peripheral resistance, the resistance you have to press against, if you increase that resistance, you're going to decrease your stroke volume. You're going to decrease the ejection fraction. And by definition, there's going to be blood still left in the heart. So you can see here, our end systolic volume or blood left after the contraction is higher. Okay, quickly, the splitting gets a little tricky. The only one that I think is super important to talk about now is this physiological splitting. The point is when you take a deep breath in, you get a negative pressure in the thorax, right? So what happens is you get a rush of venous blood into the right atrium. So therefore, there's more blood going out of the right ventricle. So actually the only thing that happens is that the pulmonary valve will close later than the aortic valve. That just means because you took a deep breath in, because of that that decreased intrathoracic pressure, that vacuum that forms, you're going to get more blood to the right side. So the pulmonic valve is going to close a little bit later. Okay, let's get into the murmurs. This is the last section. Or no, and then we'll look at the imaging real quick. So this is super important. They're going to test you on this. Remember that a stenosis is flow against an open valve. So the valve's stiff. It's not opening all the way. It's stenotic. So that you have to press against, the pressure you have to go against is that stenotic valve. The valve's supposed to be open. So it's anterior grade or forward flow. Regurgitation is flow against a closed valve, okay? It means the valve's supposed to be closed, excuse me, the blood's supposed to go in the opposite way, but for whatever reason, this valve that's supposed to be closed is opening a little bit. So it's causing blood to go backwards, regurgitating back. Okay, so with that being said, we're going to talk about systolic versus diastolic murmurs. Just so you know, we're going to use the left side of the heart, but they do pretty much correlate to the right side as well. But the left side being the stronger heart means the valves have more problems throughout life. We'll touch on these two, a PDA and a VSD. So quickly, so let's talk about systole. So during systole or ventricular contraction, we want the mitral valve closed and the aortic valve open, right? Because we're pushing blood from the ventricle, the left ventricle, through the systemic circulation. So that being said, if you have a systolic murmur or an ejection murmur, the aortic valve is supposed to be open. If there's a problem, then it's stenotic. The mitral valve is supposed to be closed during systole or ejection. So if it's closed and blood's flowing backwards, that's a regurgitation. So these are our systolic murmurs. So that's the first thing you want to determine. Is it during systole or is it during diastole? So you can see here, and like I mentioned in the chat, you see aortic stenosis commonly in older people. It's a pathologic problem that tends to happen with age. You can see here, this is that crescendo, decrescendo. So this is the sound. So it kind of peaks, the sound peaks and then it drops. That's the crescendo, decrescendo sound. Let's look at this here. So this is from first aid. You can see the volume here, crescendo, decrescendo, and it's during ejection, right? It's during aortic stenosis. So here, if we look at this blood pressure, obviously, if you're pressing against a stiff valve that won't open properly, you're going to increase in pressure, okay? This left ventricular pressure. But most importantly, I want to look at this graph. So if you're pressing against a stiffened valve, you're not going to be able to properly eject, right? And you're going to, first off, you're going to get this increase in pressure against the valve, but you're also not going to be able to eject all the blood you want to. So basically, you're going to get an increase in systolic volume. After ejection, there's a lot more blood left in the ventricle because you couldn't get it all out against that closed or that narrowed valve. So even if you did the math here, you would say in diastolic versus in systolic, you would get a decrease in stroke volume. So for mitral regurgitation, obviously during ejection, the mitral valve is supposed to be closed. You're going to get this pansystolic murmur, right? So all the way through systole, between S1 and S2, it's going to just be a pansystolic or a holosystolic murmur. So if we look here, you can see the sound here, right? It doesn't crescendo, decrescendo, it's straight across. So again, the problem is that you're going to get an increase in diastolic volume. Now, why is that? Well, if a lot of this volume that's here in diastolic volume, meaning in filling volume, a lot of this volume of blood here is because you regurgitated flow back into the atrium. So it's a very inefficient process. You know, you're supposed to eject blood straight to the systemic circulation, but every time you do that, a fraction of the blood's going backwards. Therefore, all the blood coming back into the heart plus the blood you just regurgitated back into the left atrium is coming through. So you're going to get an increase, a drastic increase in diastolic volume. Now, you may say, well, if I'm increasing stroke volume, what's the big deal, right? I'm still getting blood out. But the problem is you're making the heart work too much. There's a delicate balance in the heart. You don't want it to have to work too hard. You don't want it to be too strong or too weak, right? You want it to kind of stay in the middle. If it's too weak, you're not getting enough blood. And if it's too strong or acting too much, then you're going to get hypertrophy of the heart, and the ventricle or the chambers are going to get smaller. Okay, so you can see here, you do get an increased stroke volume, but again, it's a lot of that stroke volume is going back into the atrium, right? So it's a very inefficient process.
Is that also a decrease in cardiac output?
Yes, right. No, I'm sorry. You actually do have an increase in cardiac output for mitral regurgitation. Stroke volume will correlate to cardiac output, yeah. But again, it's a very inefficient process. So diastolic murmurs. So during diastole, the heart's supposed to be filling. So if that's the case, then the aortic valve should be closed and the mitral valve needs to be open so the ventricle can fill. So we'll get an aortic regurgitation and a mitral stenosis in this situation. Here, obviously it's between the S2 and around to the S1 part during filling. So yeah, you're gonna get this decrescendo murmur. So here it's very similar to the mitral stenosis curve, so be careful. If we look at the volume here, it's after the S2, it's during the filling phase, okay? So if we look at this here, again, if you're regurgitating blood back into the ventricle, you're going to have an increase in diastolic volume, right? It's inefficient. You want the blood to go to the systemic circulation, but a lot of it's coming back in. The thing you want to make note of is you do get an increase in systolic volume. That's that big difference between mitral stenosis. Remember, the mitral stenosis came back here because you were getting a decrease in systolic volume. But here you're actually getting an increase. And obviously the stroke volume is increased. You will get an increased cardiac output, but it's an inefficient process. Again, you're making the heart work too hard, because a lot of that cardiac output is blood that's regurgitating back in, right? So even though you're pumping it back out, it's coming back in. And then mitral stenosis, again, this is during diastole. So that mitral valve is stenotic. When the ventricle is supposed to be filling, blood that's supposed to go into the ventricle has to go against that narrowed valve. Again, you're going to get it during diastole after the S2 phase. Typically, that buzzword you're going to look for is that opening snap. So the valve's stenotic, and then it finally just kind of gives way. It just snaps open. But here, what you want to take note of is that you're going to get a drastic decrease in diastolic volume. Why is that? Well, that's because the mitral valve, the blood can't get into the ventricle, okay? It's pressing against that stiffened mitral valve. And if that's the case, between the cardiac cycle as it's pumping, it just doesn't have enough time to get into the ventricle. So here you'll get a decreased stroke volume and therefore a decreased cardiac output. Put stars here. You can use the buzzwords if that works. But just first of all, you want to say, if they ask in the question, you want to say, okay, where are they at? Second intercostal space, fifth, are they at the apex? Then you want to say, is it systole or diastole? Is it during filling or is it during the ejection phase? And then you want to say, well, what kind of sound are we talking about? What kind of murmur, if they give you that? And then you can kind of try to determine which murmur we're talking about. I just put this was kind of like a compilation of things from first aid. Quickly, VSD, you're going to hear it, it's pansystolic, right? So it's during that ejection phase, right? You're going to get shunting of blood from the left side to the right side, a left to right shunt. PDA, remember, it's a continuous machine-like murmur. It goes across systole and diastole. I'm pretty sure that's the only one we talk about that covers both systole and diastole. So keep that in mind. Quickly, I just wanted to touch on this. I know this gets confusing because we don't get a lot of practice with this, but you just want to orient yourself. Obviously, this picture, you're looking here at the apex of the heart. So that's the left side. The aortic knob here sticks out. Here, obviously, as I stated, the legs come out from the screen at you, the patient's laying. Find the vertebrae, find the sternum. You know the right ventricle's on the front side, left atrium's on the back. As Lindsey pointed out, this orientation of what is next to what helps a lot. You can see the descending aorta here, the esophagus here, and then you can see the mediastinum or the different portions of it. And then, yeah, here. So again, you just want to orient yourself. This is a CT scan. You could see the arch of the aorta coming up here, the left side of the heart, the right side of the heart. So, and then the brachiocephalic vein. One of the tricky things, there is a brachiocephalic trunk, that's arterial. The brachiocephalic vein feeds into the right atrium, that's venous. Lastly, just put this picture here. Obviously, you can see this air-filled spaces, the trachea, that's why it's black. The aortic arch runs right here. And you can see, you'll get into more of the pulmonary stuff later. Thoracic aorta is going to give blood down to the organs of the abdomen and the lower extremity. And that's all I have. Do y'all have any questions?
I have one question about when you hear the S3 sound.
Okay. So go ahead.
Oh no, go ahead.
I was just going to say it's right after the S2 sound.
So, but wouldn't that be relaxation?
Wouldn't it be what?
Like during the, so would it be during the relaxation if it's right after S2?
Yes, it'll be during diastole, so the filling phase. So yeah, it'll be during that. I think
between filling and relaxation, or?
Yeah, I mean, they both kind of happen at the same time. That relaxation of the ventricle allows time for the ventricle to fill. But remember the S4 is also during diastole, but it's right before S1. But it's a S4, then S1, then you can get S2, and then S3 is right after S2. But if I can't remember exactly, but if you look at what the pathological problems are for S3 and S4, that should be good enough for this test.
So I wanted to clarify something because Brady said it, I put it in the chat, but just an effort so everybody knows, with respect to imaging, if it's a patient laying down, you are standing at the foot of the bed and the patient is laying down. So you're staring at their feet. So your left is the patient's right. If you have a coronal view, you are standing in front of the patient unless otherwise explicitly stated, like in an x-ray or something like that. And so whenever you're looking at imaging, it's always oriented the same way, either at the foot of the bed or standing in front of the patient. So you kind of need to flip left and right whenever you're looking at structures. Does that make sense, guys? That'll help you whenever you're looking at any imaging study.
So I have a quick question. Sorry, go ahead.
Oh, I have a question about the aortic regurgitation. Why the end systolic volume is higher?
Because you're not getting blood out.
Okay.
Essentially, yeah. Simple as that.
Yeah, the end systolic volume is going to be the volume after contraction. So if during contraction you're pressing against the stenotic valve, you don't have time to get all the blood out.
Okay, got it. Thank you.
No worries.
Okay, in an athlete, you know how athletes have a higher stroke volume? Does that mean that their cardiac output is higher? Because I think it would be the same, and the heart compensates by lowering the heart rate.
I think so the cardiac output can go up, like when they're like if they're a sprinter or something during during an athletic event, but generally their cardiac output stays the same, but that's just because they have such a decrease in heart rate, right? Their heart rate's like 50, but they have more volume going out because it's stronger.
And that's because their stroke volume is normally higher and the heart rate is normally lower. That's why they get the same output, right?
Right, yeah, because of training, yeah.
Thank you. Thank you so much for your time. I really appreciate it. You guys put a lot into it. Thank you so much.
No worries. Yep.
Thank you.
Have a good rest of your Sunday. Thank you so much.
You guys too.
No worries.